We're fortunate to have Matt Gutwein with us today. He's the CEO and president of the Health and Hospital Corporation of Marion County. And before he gets started, I just wanted to say a few things about Timmy Global Health in general, what we're trying to do with this speaker series that's going to last the entire semester, as well as our chapter here locally of Timmy Global Health. So the goal for this speaker series is going to be a semester-long conversation basically focusing on underserved patient populations, both locally and globally. We're going to start off with some individuals that work here in Indianapolis, and then transition to some more global health topics a little bit later on in the semester. Timmy Global Health, for those of you who are unfamiliar with it, is an organization that's based here in Indianapolis. The mission is to fight health equity issues, both locally and internationally. Typically they work in 4 different countries, Ecuador, Guatemala, El Salvador, and the Dominican Republic. And how they operate is chapters like ours here at Marian University. And every couple months they send a group, there's about 35 chapters across the country, send a group to the different sites that they have in those 4 countries and set up mobile medical clinics. And the students go with medical professionals that they recruited for those trips and see patients basically. And so it's a great way to have continuity of care in these communities, as well as manage chronic patients. What we're doing here locally is helping to support that through all the efforts that they do. We actually have a partner in the Amazon River Basin of Ecuador, which is Stadler Richter Hospital. So all the fundraising efforts that we do are going to support the efforts of Timmy Global Health. We're also going to try to connect students to local organizations for community service opportunities, as well as put on events like this where we can have conversations about global health issues, both locally and globally. And so I've talked a ton, but if you have any more questions for me, you can email me. The flyer that was sent out has my email and contact information below, but I definitely want to get to our speaker. Matt Gutwein, like I said, is the president and CEO of Health and Hospital Corporation, which is the organization that oversees Wishart Eskenazi Hospital, as well as the Marion County Public Health Department. So we're fortunate to have him. Thanks.
Well, thank you, Zach, for inviting me today. Thank all of you for coming and participating in this conversation. Warmest congratulations on being the inaugural class here at Marion. That's a fantastic distinction, and thank you for choosing to join this noble profession. And thank you for having me today in this extraordinary facility. Also, I just think the world of the president of the university, President Elsner, just an incredible individual, and so I'm just so excited about what's happening here and what all of you are participating in, and both the medical training you're getting, but also the values you're receiving to go out and care for patients, particularly with an emphasis on the underserved. And thank you for coming to this lecture today, for Zach putting it on with Timmy. Zach and I used to work together. Zach worked at the Health and Hospital Corporation with me, so I'm great to see him as a medical student now. So I'm going to talk a little bit, but I hope you will interrupt me. I hope we can have a conversation and a dialogue, and it's not just a monologue with me up here rambling on. So I want this to be what you want to talk about rather than what I want to talk about, because I listen to myself talk all the time. So, but let me just tell you a little bit about what we do at what is now called Eskenazi Health, and a little bit of our history. So we are the public hospital in Marion County. We are the safety net hospital. It is our privilege to care for the indigent and underserved in our community. We are the oldest hospital in the city of Indianapolis. And we started out in the early 1850s when there was a smallpox epidemic in the city of Indianapolis. And the leaders of our city took those sick individuals who suffered from this illness and sent them over next to the river buy the city dump to live in tents so they would not affect the rest of the residents of our city. And that tent city continued to grow and existed for years, 4 or 5 years, till finally a couple of city leaders, in an act of compassion, said we need to build a building for those sick individuals, and we need to meet their needs, not only their medical needs, but their social needs as well. And when that building was built in 1859, a very simple wood frame building, that was the beginning, what was then called City Hospital, and was later called General Hospital, and after that, Wishart Hospital, and now Eskenazi Health. And so from those very humble beginnings, they were built on an idea, and it was an idea that continues today that I think that all of you are participating in as well, which is that there are persons in this community who need to be healed and need to be cared for, and otherwise do not have the means to do it themselves and need help. And we should all collectively, as a community, come together to provide the help that we can. And it's been an incredible ride since that early 1859 when that simple building was built. So City Hospital was the very first hospital to care for African American patients in our city. The very first hospital to hire African American physicians. The very first hospital to hire African American nurses. The very first hospital to train, as you are now, African American doctors so they could go out and care for others all around the state and nation. The very first hospital to do the same for African American nurses, train African American nurses to care. The very first hospital in the nation to have a hospital-based ambulance system, which was in 1872. It was literally a horse and buggy. It was the first hospital to use two-way radios in the late 1930s on the ambulance system with the hospital. The first hospital to have an iron lung, which is now a respirator in the state of Indiana. We were the first hospital in the nation to have an electronic medical record. We've had our electronic medical record for over 40 years in conjunction with the Regenstrief Institute. So the Regenstrief Institute, which is affiliated with the IU School of Medicine, developed the theoretical technology, and then we were the laboratory for that. We were the first system in the state of Indiana that had a community mental health center. And we are by far, to this day, the largest provider of mental health services in the state of Indiana. About 600,000 visits a year. We're the first burn center in the state of Indiana and are now certainly one of the premier burn units in the country. We're the very first level 1 trauma center in the state of Indiana, still one of only 2 level 1 trauma centers. I could go on and on and on. We're now in about 35 sites around Marion County, most of those sites being areas where we provide primary and preventive care and mental health services, and then the central hospital. But through all that, our main job is to care for everybody who needs care, with a special emphasis on the indigent and underserved, and it's trended that way for a long time. So for example, 8% of our patients have commercial insurance. And there may be another hospital system in the country that has a larger or smaller percent, but we just haven't found them. We don't know of any other hospital system that has even less than 8% of our patients have commercial insurance. About 20% have Medicare, 30% have Medicaid, and about 42% of our patients are what are called self-pay in the industry, which means they don't have insurance at all, which essentially means they have very, very little means to pay. We care for an incredibly diverse population. For example, last year, we cared for patients that spoke 180 different languages from 135 different countries of origin, and representing every possible socioeconomic, ethnic, age, range that really you can imagine. and we try to we try pretty hard to do that in a very efficient way. So am I boring you all incredibly? Okay, all right. You can please jump in and stop me. But there's a lot of actually national data that you're required to submit when you're a hospital. Turns out, a healthcare system, and on all that publicly submitted data, we are actually one of the highest quality hospitals in the country, and actually one of the absolute lowest cost. In fact, there's something called the Dartmouth Atlas that studies actually every single hospital in America, all 5,200 hospitals in America. And it's reams of information. You can actually, if anybody's got a laptop, you can look it up. It's got gazillions of information on it. But they've got this big summarizing tool where they take every hospital in America and they put them on a 1 to 100 scale. And so it's a curve, right? That looks at both your quality indicators as well as your cost. And if you're 100 on that scale, that's a very bad place to be. You don't want to be 100. If you're 50, you're in the median. And if you're in the bottom, so for example, like the UCLA hospital is 92. That's not a good place to be. So on that measure, we're 5.9 on their scale, which is, they think we're doing a pretty good job. And so we're sort of low cost, high quality hospital, and with relatively few of our patients that have the ability to pay. So how do we try to get that done? And let me offer a couple thoughts about that. And again, I'm begging you to interrupt me at any moment here. But historically, hospitals and doctors have been paid on the fee-for-service model, right? And so the more things that a hospital or a doctor does to a patient, the more you get paid, right? And the ordinary laws of economics would suggest that creates a perverse incentive, right? In fact, there's actually no incentive for patients to be extremely well, because if they're well, you're not generating income. But for us, when only 8% of your patients have commercial insurance, providing more services that don't make a person well actually is against our interest. And so we actually have this incentive to provide the exact right amount of care, because if you provide too much care, you're wasting money. But if you provide too little care, it turns out that's going to be bad for the patient. The patient's going to not be well if you provide too little care. And it also turns out in many instances, it is economically disadvantageous for us as well, because when a patient gets less care, they'll probably come back. And when they come back, they'll come back more sick. And in fact, we actually did a study, because we can do this with our electronic medical record, that overall for our patients, this is on the gross, that when a doctor orders a prescription for one of our patients, and if that patient leaves our healthcare provider without filling that script, the cost of care for us goes up by 90% for that patient. Yeah, amazing, huh? So we have all these methods of making sure that when we order a script, you do not leave without that script. We physically tackle you if we have to get that script in your hand. But no, I mean, we don't physically tackle you. But what we do is we say, if you're at 200% or below the federal poverty level, if we give you a script, no matter what that script is, no matter how much it costs, it will cost you $5. That's it, no matter what. Because for us, it is far more economically advantageous to subsidize the cost of that script and give it to you for $5 so you can afford it. So you'll get, and then we have a pharmacy at every single building, and the pharmacy is right when you check out. Right, every building has a pharmacy, and it's right at the door where you leave. So we send you, so the doctor immediately gives the script and sends you to the pharmacy. We through our electronic medical record, zipped it to the pharmacy, so the pharmacy has it waiting for you when you leave. And we hand that to you, and it's $5, and that's it. And so then you leave with that script. Yes, sir?
With it only being $5, what do you guys find your compliance rate is? Because I just read an article yesterday that said nationally the compliance rate is like 40% of people fill their prescriptions.
Right. Yes. So our compliance rate is much higher than that, right? It's well above the 90s because, and it's not just the price. I mean, we have a system in place so that we channel the person to the pharmacy before they leave, and have the price that low, and then hopefully have a good system where we don't have to stand in line for a long time. Now all these things sort of break down, but that, yeah, because we want that compliance to be very, very high. So we have never operated under the fee-for-service model as giving us an incentive for providing lots of care. In fact, there's some incredible studies that show that anywhere from 30 to 50% of all care, this is nationally, not at our place, but overall, nationally, anywhere from 30 at the low end to 50% of all care that doctors and hospitals provide patients make absolutely no difference in the person's health. Doesn't make it better, doesn't make it worse, it's irrelevant. And think about that. But what it does do, that care, when you're providing 50% or 40% or 30%, it does generate fees for hospitals and doctors, and there's little incentive not to do that. But we don't have that incentive. So we actually have the incentive of doing everything you can to make people well, because that actually gives us the resources to care for more patients. Because our biggest challenge is that we have much more demand for our services than supply. So we work very hard to sort of hit that exact target with issues of keeping people as well as we possibly can. And so a lot of times we think about doing things that most people would say aren't the practice of medicine at all. But what they are things that keep people well. And let me just give you a couple of examples. And I'll start one that it really is the practice of medicine. So a couple of years ago, Indianapolis, Marion County popped up as having the highest infant mortality rate for minorities in the country. A shameful fact, right? A horrible thing. And a lot of the reason for that was really poor prenatal care for pregnant women. And so and so it was not only a very high, I mean, the infant mortality rate was very high, but it was also an extremely high number of premature births as well, which is also very bad. A premature baby often is going to suffer a lifetime of illness and often disabilities. And it's also, for us, a premature baby is an incredibly expensive patient. They require very intensive care for 24 hours a day for often months at a time. It can be $1 million patient like that. So what we decided to do is hire this army of nurses whose sole job it was that if we located in any possible way an at-risk pregnant mother, and usually that risk was based upon her level of income, so low-income woman, if we could find out that a low-income woman was pregnant, then we would send a public health nurse to the woman, whether it's to her house or to a place of employment or wherever. In other words, we didn't wait for her to come and get her prenatal care. We sent her to the woman, and that nurse was assigned to that woman to meet every need that she possibly had. So would bring her prenatal vitamins, and would make an appointment with her to visit her OBGYN, go there and drive her to her appointment. In order to do everything you possibly can to make sure that the full range of care necessary to have a successful pregnancy occurred. And it turns out it has been an incredibly successful program. And both the infant mortality rate and the premature birth rate improved dramatically extremely dramatically, so that we went from the worst in the nation to the sort of in the best 25%. It's actually gotten a little worse more recently. And so it was the right thing to do for the health of the mother as well as the health of the baby. But it turns out it was economically in our best interest as well, because it was far cheaper for us to have 50 public health nurses on our staff than to have even $1 million premature baby counts. This was an incredibly successful program. Let me give you a second example that's sort of along those same lines. So it turns out that the most common reason that a child comes to an emergency department, this is our hospital as well as all of the nation, is because of asthma. And the most common type of asthma for that child is environmentally induced asthma. Okay, so asthma caused by mold in the apartment, or dust mites, or you know, infestation, things like that. And most of that asthma is incurred by families that live in substandard housing, right? So housing where the landlord is not properly caring for that home. So these are low-income individuals, and they've got a landlord who's not doing his or her job. And so we take care of these kids all the time, and our doctors are fantastic at remedying the symptoms of that asthma. But when you take them home, and it was the home that actually caused the asthma, that just means the child's going to come right back, right? So we started this program. We actually stole this from Mass General Hospital out in Boston, and we are eager to steal any good program that exists. So we started this program. It's called the Medical Legal Partnership, and the program is that the lawyers in our city agree on a pro bono basis to give their services to help us with these kinds of social or legal needs that our patients have. So in the case of asthma, when our doctors see a child like that and realize it's an environmental induced asthma, and might talk to the mom a little bit about their living conditions and ask them about it, we just have a little system, send them to one of our lawyers who are in these big law firms who love to do this for free, and then lawyers do what they know how to do, which is write a letter to the landlord reminding that landlord of his or her or its legal obligations and the consequences of not following those legal obligations, and demanding that the roof get fixed so the water no longer drains, you clean up the mold, and you actually replace the carpet, you do all the things that you're supposed to do as a landlord to no longer have substandard housing. So that it actually cures the underlying cause of the child that's coming to us. And this place, and I'm only mentioning asthma as one example, there's all kinds of social or other legal needs that families have that then induce illness, and the doctors and the nurses can cure that illness but can't cure the underlying cause, but lawyers can. And this has been an incredibly successful program for us. It has helped thousands and thousands of patients, and it has improved the overall health of our community, and it's actually cost us not one thin dime. And actually, it's really fun for the lawyers because they can actually help someone, very, very immediately. And a lot. Most of our lawyers are in these very large law firms, and most of the time, they're representing these banks or these insurance companies. And that's all fine. We all love banks and insurance companies, but sometimes it's great to help a real person, right? That's a family that's struggling. So it's been a really wonderful program, and it also greatly improves the mood and spirits of our doctors and nurses, because previously they knew all they were doing is helping the symptoms, but that patient was going to come right back, and now they realize they've got a tool at their disposal that can actually cure the underlying problem. Let me give you a third example. Or do you have a question? Okay. Let me give you another example. We care for very large numbers of our homeless neighbors. And being homeless is not good for your health at all. It's a very bad thing for your health. And many of our homeless neighbors that we care for also suffer from mental illness. And indeed, their homelessness is often a symptom of their mental illness. That if you could help them with their mental illness, then they're capable of being productive and well-adjusted members of our community and wouldn't be homeless. And so for years, we were providing enormous amounts of care for our homeless neighbors, and it was often very expensive because often our homeless neighbors would be sick, out, in the community, on the street, on the bridge, and a police officer might find them, or a citizen might see them and could tell they're ill and call a police officer, and then you'd call an ambulance, and the ambulance would come and pick them up, which is an incredibly expensive ambulance. It's about $2,500 a run, and then you come to our emergency department, and then you check in, and they become an inpatient, and they might be an inpatient for a week or so to correct this infection, or this diabetes, or this, and then when they're healed, you send them back out, and being homeless is not good for their health, and they're just going to end up right back. So we got a little grant early on. This was about 10 years ago, and we started experimenting with this idea of what would happen if we would actually provide housing ourselves. We would rent the housing units or buy them, and we would actually provide housing for our homeless neighbors who suffer from mental illness. And then we would, similar to the public health model with the nurses, we would take our professionals and go to those individuals where they're living and provide care for them there, with a particular emphasis on their mental health, so allow them to make sure that they're complying with their drug regimens, right? So they're taking their medications, and have counseling services, and help them make their appointments, and in other words, provide services there. We thought, what would happen with this? This is a model that might make sense, and could you do it economically? We knew it makes sense from the care perspective, but the question is, it could just be wildly expensive, and as much as we'd like to do it, it wouldn't be feasible. Because we have electronic medical record, we can pinpoint to the penny how much it cost us to care for patients before this, and then how much afterwards. And lo and behold, it turns out with this model that it is vastly better for the care of the patients, vastly better. Literally thousands of previously homeless patients who suffered from mental illness, through this model, we could work with them on their mental illness so they could be well adjusted and no longer be homeless, which is good for them, good for their families, and of course good for our community. But the great part about it is we also learned that it was economically exceedingly less expensive for us on this model as well. In fact, on average, what we learned was the patients, our homeless neighbors before this program, were spending 11 days a year as an inpatient at Wishart Hospital. And once they were onto our program, that number went from 11 days a year to less than 1 day a year, which is, and usually if you're an inpatient, it's about $3,500 a day as an inpatient. That's not counting things like an ambulance ride and other kinds of outpatient services and things like that as well. So what we learned was that it was important for us to be in the housing business. So now today, and nobody knows this. I mean, if you went around, we don't put signs on these places. But we have about 350 housing units all over our city, and therefore our patients who are homeless, and some of them we own, some of them we lease, and we provide care for these patients there, and in fact we had this one woman who, before she was on our program, she had been an inpatient at Wishart for 59 days. That's a very long stay. And this was 3 years ago. And when we invited her to be on our program, and they have to agree, we can't force anybody. We invite them to participate in our housing and be a tenant and then agree to receive their care there. And so this woman 3 years ago got onto our program, and since that time, she has been an inpatient at Wishart now Eskenazi exactly 0 days. That's been wildly successful for her. Yes, sir.
Was it based off of like the Denver study where they did it to stop homeless people from sleeping basically overnight?
Well, it was really based. There was. It wasn't specifically based on Denver. It was really based upon our own recognition that we had this group of people that we were just not doing a very good job of caring for them. It just didn't make sense to passively wait for them to come to us when we know that we're doing them a disservice by fixing those symptoms and then sending them right back out, because they're just going to come back. And so it was the thought of, we're failing these patients. We ought to be able to do a better job. And so does it make sense to actually get into the housing business? And the answer is yes, it makes enormous sense to be in the housing business. And I'd like to be in the housing business even bigger. We've got about 350 units. That's pretty big. But we still have home. And it's really designed, homelessness is of course very complex, and it's really designed for homeless who also suffer from this specific kinds of mental illness. And there are many homeless patients who don't suffer mental illness, but have other kinds of issues. But it's really sort of that. But if we could get in the business and if we could solve the puzzle in a bigger way, we would too. Yes.
Yeah, it's great to hear about all these programs, and I've lived here 10 years and seen Wishart and Eskenazi has been so innovative. Even more so than some of the other hospital systems in really promoting, what the osteopathic medical model these students are training is all about, which is, holistic mind, body, spirit, and we could add environment.
Yes.
To the root causes of health. And I was wondering if you could also maybe talk a little bit about some of the programs, especially in terms of like end-of-life care.
Yeah.
Like the No One Dies Alone, and which these students can even volunteer for if you're interested. Greg Armelsbacher's Palliative Care team, stuff like that.
Yeah. Thank you so much, Jason. Yeah, we have. That's sort of a softball lob to me. Let's see if I can actually hit it. Give me one. Can I answer? Should I?
I have a question about what we're talking about right now.
Okay. All right. Because I'm going to get to that.
How many people are in each of your housing? It's or does someone stay with them, or how does it work?
No. Yes. So it'd be an individual unit. So you'd have your own apartment, and no one's. So it varies. So the apartments are clustered. So some of them, the largest one I think has 30 units there. It's part of a larger building, but there would be 30 that we rent. Most of them are about 10, right? So they're clustered there, and so we might have someone that's a sort of is there all during the day, but wouldn't be there at night. And the reason why we cluster them is really for our own efficiency. So we want, when a counselor goes, the counselor can move from one unit to the next, to the next, to the next, or sometimes there's even a group area, a group session for group therapy, and then you can pass out the meds and that kind of thing. But it also, in part, depends upon the needs of the patient. So some of the units we have are for more intensive care than others. So it really varies. Most of them are about 10 units in one place.
Sorry for the follow-up.
Yeah. I should know the answer to that, how many turn it down. But we try pretty hard. With folks that suffer from pretty serious mental illness, we have a variety of strategies for those folks in a continuum of care. So, we have an inpatient unit at our hospital. If you're really sick, you're going to be there. And then we have enormous amounts of outpatient care. In fact, we are, if you ask me the one area that we are putting the most resources in and expanding our services the greatest, it's in the area of mental health. And what we're finding, particularly for low-income individuals, but it's not at all limited to low-income individuals, but particularly for low-income individuals, the incidence of mental health issues is incredibly high, and you really can't treat their non-mental health issues unless you're also treating mental health issues. So we've recently really changed our model greatly. So now in every one of our primary care centers, and we have 11 of those throughout the community, every one of them, we provide mental health services right there as well. So when someone comes in for whatever, every one of our doctors is trained to do a mental health screening, and if they diagnose a mental health issue, they will just go right down the hall and say, please see this mental health professional and work on your mental health issues as well. And we're expanding even greater. So yeah, there's an enormous unmet need for mental health in our community, and greatly with the low-income populations. Yes, ma'am.
So you started this program with a grant
Yeah.
10 years ago.
Yeah.
How are you reimbursed today for the housing issue and the delivery of care that's so different?
We are not reimbursed at all for the housing. We fund that ourselves, and so this is the issue for us economically, that we are reimbursed for the actual medical care that we provide, and well, I shouldn't say we're reimbursed. It depends on the patient. So if it's a Medicaid patient, we would give a Medicaid rate. If it's a Medicare patient, but for the majority of these patients, they would be just completely uninsured. So we wouldn't receive any direct reimbursement. We do get funding. It's called disproportionate share funding. Those are supplemental Medicaid patients, and so that's some reimbursement. But most of the time we're not getting reimbursement. So that's exactly why we do it, right? So the question is, if we are not getting reimbursed as an inpatient, and the cost is 10, and we're not getting reimbursed with our housing unit, and the cost is 5, and the 5 is far better care, far better for the patient, why wouldn't we choose to lose 5 as opposed to lose 10? I mean, that's what it comes down to. How can we be the absolute smartest and most strategic in using the limited resources we have to meet the patient's needs? And what we found, that it's a lot smarter to rent a housing unit and provide the care there than being passive and wait for them to be an inpatient at Eskenazi Health. That a hospital bed is a lot more expensive than renting at 30th and Cold Springs Road, 10 units, and having folks come. So that's really what it comes down. We are not reimbursed, and that's why we have the incentive to be innovative, to be in the housing business as opposed to the billing business. Yes, ma'am.
So statistically, what do you think with your mental health patients also suffer from substance abuse and they are self-medicating?
Oh yeah.
And don't really realize
Sure.
that.
Right. Oh, it's a very high number. It's an unquestionable high number of people who self-medicate as a result of their mental health issues. Yeah. And the reimbursement for substance abuse is almost nil. Yeah. All right. I want to mention palliative care and no one dies alone. So this is another. This is the exact same issue of how do you really do what's in the best interest of the patient. And as most of you probably know, that we spend enormous amounts of money in this country on healthcare, but it turns out that 50% of every bit of spending that we'll spend on you in your entire lifetime is spent in the last 3 months of your life. So at the end of life, ordinarily, is when you have all of these surgeries to keep you alive, and all this incredible intensive care we do, and if you ask most people how they want to die, if you ask them, do you want to die in the intensive care unit of a hospital, having just had 5 surgeries, and you're on a respirator and oxygen, and you're not communicative with your family, and you're in a drug-induced coma, and your family is living by your hospital bed for 2 months. Is that the way you want to die? Or would you like to die in your home, in your bed, with your family around you, where you can say goodbye and your needs are met? You choose A or B, right? And most people would choose B. But if you leave it up to most hospitals, they'll choose A. They'll do everything they possibly can. So this fantastic doctor at the IU School of Medicine, who's worked for us now for over 30 years, Dr. Greg Grausmacher, just an incredible guy, wonderful doctor, and his area was actually medical ethics, said this is just ethically wrong for all these patients to be giving them surgery after surgery after surgery after surgery just because we can, and not because it's what they want, and it's because we're not giving them any other opportunities. So he started this palliative care program where he works with other young doctors and medical students, where the sole purpose is when someone has a terminal illness, and it's terminal, and so the question is not when you're going to die, but how you're going to die. He works with them to say, what needs do you possibly have? And what can we do to make the end of your life as comfortable as possible, and to meet your needs, and to make you as happy with you and your family as you possibly can, instead of being hooked up to machines. And so we have this incredible, and it's been remarkable. In fact, I'll just give you an example. There was a gentleman named, his nickname was Cowboy. I think his name was Robert Cowboy Williams. And Cowboy was a homeless gentleman. He lived right under a bridge, pretty near the old Richard Hospital, right on 16th Street. And Cowboy came in, and Cowboy had very late stage lung cancer, and Cowboy was going to die. And so he went into the palliative care program, and so he was in the hospital, and Cowboy would drive our staff crazy because he'd be in the hospital, and all of a sudden he'd go missing. He'd be gone. And then he'd come back. And they'd ask, "Where'd you honor him?" And he'd be gone again. So finally they followed him one time. And what he was doing is Cowboy had a dog named Cowgirl. And Cowboy was so worried about his dog Cowgirl that he was taking food from the trays and going out to the 16th Street Bridge to make sure the Cowgirl could eat. All right. So one time it's on this crazy cold night, just like now. It was a January night, and Cowboy was in his place under the 16th Street Bridge, and our palliative care team said this was too crazy, and they went down. They actually brought a kerosene lamp, and they tried to hook this thing up underneath to the heater to try to hook it up, and even that wouldn't work. So they convinced him to take a hotel room, and so he did. And we got a call the next morning that the hotel staff had found him lying on the floor. He was very ill, so we rushed him to the hospital. And it was going to be, it was very close. And they asked him one last time. They said, "Cowboy, if there's anything I can do for you," and he said, "I want to see Cowboy." And so our staff went out in the dead of winter, 0 degrees, and went over to the 16th Street Bridge and looked around and found Cowgirl. And they put her in the car, they brought her in, brought her to the hospital, and literally when they walked on the floor, Cowgirl jumped out of their arms, went running down, went into Cowboy's bed, jumped up, and jumped onto Cowboy's bed. And I'm sorry, it's a sad story. And when Cowgirl arrived in the bed, Cowboy died. And my only point in telling that story is that when you ask people what they want, they'll tell you, and then they're ready to die. And through Greg's program, again, we'd like to think that it's absolutely in the best interest of our patients, that they're getting what they really need. They're dying the way they want to die. They're dying with dignity, and they're dying with peace. But it turns out it's also in our economic best interest. It's far, our resources can go far further when we're not providing 25 surgeries at the end of a person's life, and they're spending their time in the intensive care unit. And so it's been, so we now have this program called No One Dies Alone. And because that turns out is one of the greatest fear that people have, particularly people who are homeless or people who don't have a family near here. Death is a scary thing, so the idea is just that you won't be by yourself when you die. So we have this program where you sign up, and you're assigned an individual who has a terminal illness. And you come and early on you form a relationship with that person, you get to know that person, and you just, if they want to watch a ball game, you watch a ball game. If they want to read the New York Times, you read the New York Times. If they want to watch a movie, you watch a movie. But then you make it your business that you know you're monitoring them, and when they're ready to go, you'll just be there with them. And it turns out that one small thing, that simple little act of someone knowing that I've got a friend who's going to be with me, and they'll be in this together, is enough for many people to face that decision. So it's been a very, very successful program, and I consider it. And any of you we'd be honored to have you as volunteers. We actually literally have hundreds of people signed up for No One Dies Alone, and I think many of the volunteers will tell you that it's as meaningful to them as it is for our patients who are dying as well. Let me tell you one more, and I want to get your questions, two more of your questions, but one more example of doing things that have, in many ways, have nothing to do with medicine at all, but ultimately. So we see, as a level 1 trauma center, we care for very large numbers of victims of violence, okay? Victims of gunshots, knife wounds, and others. And many of these victims of violence are persons that have engaged in dangerous activity, right? They're engaging in a dangerous lifestyle, and that's how they ended up, being coming in an ambulance, with gunshots to their abdomen. And we discovered this incredibly disturbing fact, again through our electronic medical record, that when someone comes to us, a patient comes to us as a victim of violence, that kind of violence, intentional violence, that 35% of those patients come back to us a second time, at least a second time, as a victim of violence again. 35%. In fact, we had one gentleman who came back to us 7 times. And so what that tells us is, folks they're engaged in this dangerous lifestyle. They get shot. Our doctors patch them up, send them back out, and they don't do a lifestyle. So we started this program again that we stole shamelessly from San Francisco General Hospital. We call it Project Prescription for Hope, and it's based upon this incredibly simple, easy insight, which is this: that when a young man, and most of these are young men, I mean, they're all, there's some women, but almost all of these are young men, comes in and they're lying on a gurney and they've just come out of surgery and they're not really sure whether they're going to live or die, it turns out that moment, that earliest possible time, is a teachable moment. At that time, you've sort of got their attention. And if you give them another way out at that time, there's a possibility of actually changing their lifestyle around. So again, based on this program, so we hired these social workers who themselves previously were involved in a very dangerous lifestyle and turned their lives around, and now they're master's degree in social work. So they intervene. That's the idea. So you intervene with these individuals at the earliest possible time, right when they get out of certain minutes. The moment it's safe, you intervene and you talk to them about their lifestyle and other options that are available to them, and you do what social workers do. So if they have an alcohol problem, you connect them with a substance and alcohol abuse program. You get them connected to a favorite high school teacher. That you do all the things that it takes to change their circumstances and give them an opportunity. And you work with them as a caregiver and a social worker. So we've been doing this program now for 4 years, and it's been involved with hundreds and hundreds of patients. And our recidivism went from 35% to 1%. And we have story after story. In fact, one gentleman, I'll tell you, this gentleman's name is Joe. He's in high school, and he came to us on a Saturday night as a gunshot. That Monday, what was going to happen when he went back to school, he was going to be expelled from school from conduct that occurred during the week. And he comes to us as a gunshot victim, involved, his life is going the exact wrong way. He entered our program, and pretty soon, so he got back in school, he got a job, he bought a car, he made the honor roll, and he was accepted at Vincennes University. And in fact, our program, Project Prescription for Hope, actually went down to Vincennes with him, got him situated down there, made sure his needs were fine. And he's now a junior at Vincennes University. He's doing incredibly, and we have lots of stories like that. And again, that's an example. So you said, why would, we're sort of in the social services business. Why are you in the that's not surgeons and that, but I can tell you that, what we're trying to do is just meet the need, whatever the needs are, we're trying to meet the needs of the patients we have. And that's an example where certainly in the interest of these young people, it's in the interest of their families, it's certainly in the interest of our community to not have those individuals engaging in a dangerous lifestyle. And again, it turns out it's in our economic interest as well. When a young man comes in to our trauma center with a gunshot, that's an extreme, that's about a $250,000 patient right there. And our 2 social workers cost us about $125,000. So, if you even prevent one, it's economically in our best interest. And we've had now, about 450 patients involved in this program over the last 4 years. It's been very successful. Thoughts, comments? Yes, sir.
You mentioned that you don't get reimbursed by a lot of these people.
Exactly.
Some programs do start with grants.
Yes.
Where does this money come from if the hospitals just eat costs all the time? How do you keep these things running?
Yeah. So the question was, how do we keep this running? And there are 2 answers to that. One answer is that we, by necessity, have to be extremely efficient. We have to be very, very low cost, and so our costs, less than half of what most other hospitals are, and so that enables us to provide a lot of care, and then so our model is really we provide a ton of primary care. So we actually had 1.4 million outpatient visits last year. That makes us the 4th largest safety net system in the country. And most of those visits are primary care visits and mental health visits. And it turns out that the biggest bang for your buck in healthcare is primary care. That's where you can really care for the patient, get the best outcome with the smallest amount of dollars. So when you marry up primary care and mental health, you can really go a long way to treating those patients as opposed to, you know, a major, some form of major surgery. So you got to be super low cost. And then second, we do get reimbursement. I mentioned this earlier from the federal government, the state government for they're called supplemental Medicaid patients payments, but that covers about half of our cost, and not the full cost. So we, you know, we scrape and scrap, and you know, I've probably greatly overstated how good we are because there's, you know, we got a lot of problems in our system too, and the biggest one is just being able to meet the demand. And so if you today, if you wanted a primary care visit and there's nothing wrong with you, you just want to see your doctor for a checkup, we have 1,200 people on the waiting list for that, and it's going to be about 4 months before you get in. Now, that's terrible. You know, I think that's horrible. I think that's shameful. If you want a doctor, you know, if you are, particularly if you're a low-income person and you just want to come to get ahead of your health, we want to see you today for that. We want to honor that. We want to say thank you for wanting to get out ahead of your health. And if you want to come in, we want to get you in right now, but we can't. We just don't have the resources to do that. We don't have the capacity to do that. And so we're trying to continue to refine things to get that done. But our lines are long, and we have to prioritize. And so that kind of visit, even though it's an incredibly high priority visit, unfortunately we're sort of at the end of the line for that.
Well, first of all, it's absolutely outstanding work. It sounds like it's absolutely amazing things going on. I was actually wondering about if you've had any success with like gang members in terms of violence with like jumping out if they change lifestyles or anything like that.
Yeah.
Are they able to actually change lifestyles and do that?
Oh, absolutely. Yes. The question was, so Project Prescription for Hope, large numbers of those young people are gang members. No question about it. Yeah. And we've had, in fact, you should all, this is probably worth emphasizing. So it turns out that there's increasing evidence that for persons involved in the criminal justice system, that the professionals that have the most success in turning their life around are healthcare workers. It's certainly not parole officers, right? It's not judges, it's not cops, but it turns out that healthcare workers, doctors and nurses, can reach people involved in the criminal justice system in a way that no one else can. And in many ways, it makes sense, right? Because doctors, they're just there to help. They're not going to judge you. They're not going to throw you in jail. You know, they're not going to punish you in some way. They're not trying to get you to confess for the. You know, they're not trying. All they're doing is saying, I've got one job, and that is to care for you. That's the only thing I'm doing. And I'm going to try to do that the best I possibly can. And people know that. People realize that. They say, yes, my doctor is only there to try to understand how I can be better. So I'm going to trust my doctor. I'm going to trust my nurse. I'm going to trust this person who's caring for me. And I'm going to open up in a way that I'm not willing to open up to some other people, whether it's even, you know, certainly not my family member, my friends, or certainly not my parole officer or that judge. And I think that's very exciting, and that's very powerful, and I think that gives all of us a real opportunity to make a dent when no one else has been able to in the past. The Annie E. Casey Foundation actually was the first to really figure this out through some studies that were based in Baltimore. And so they, in fact, we've got one of these grants from the Annie E. Casey Foundation. They are promoting more and more for people involved in the criminal justice system, having a healthcare worker be on the front end of trying to get those individuals to turn their life around. But the real insight that San Francisco General figured out that we've been able to capitalize on is it's not enough just to try to help out, that there are these times when people are particularly open-minded to it, and lying on a gurney is one of those times. Yeah. Yes, ma'am.
So, I think you, being the leader of your institution, have maybe even brought some of these ideas to the table, but I'm just wondering how you've been able to create this culture of thinking ahead of the game. How do you promote that within the organization? Is nursing at the
Oh my
table
gosh,
these?
yes.
How do you encourage these people? Are there committees they can join?
Yeah.
Is there a think tank? Or
Well, it would be incredibly wrong of me to leave you the impression that I'm the one that created all these ideas, because I don't think I created any of them. And this culture, you are exactly right. You hit it right on the head. It comes down to culture, and it's a culture that existed long before I ever joined the organization. And so, as one of the people sort of at the higher end of the organization, what I consider my greatest responsibility is how do you nourish that culture, right? How do you make sure that nursing, we've got the cafeteria workers who are right now, they're sort of at the front edge of a bunch of stuff. We've got this enormous program on nutrition right now. We are really pounding away nutrition for both our own staff, and so our cafeteria workers who are cooking our food are on the front edge of getting very invigorated and excited. And in fact, many of these cafeteria workers, they don't have high school diplomas, okay? In fact, we've actually got a program where we work to hire homeless individuals. We've got a number of people that were previously homeless who are now working in our cafeteria, and they are incredibly excited about kale, okay? How right, they are into the kale, because it turns out that we celebrated National Kale Day at Eskenazi. We had, on National Kale Day, we had 10 different kinds of kale, 10 different preparations. We had sauteed kale, we had kale chips, we had, what we try to do is say, well, we want to be a place that's a learning institution, right? We want to be a nimble institution. We want to be an institution that absolutely is not afraid to fail, that encourages innovation and ideas, and that every idea is welcome, that we value every single person in the organization. So we want your ideas because it's hard to do what we do. It is hard to find the resources, and so we need everybody thinking about it. In fact, on this issue, so it turns out there's increasing studies on this that show that by the time a person presents themselves with an illness, to get to that point, that what healthcare professionals can actually do to affect your health is only 10%. That 50% is the individual choices that we make about how we live our lives. You know, it's how we eat, what we drink, how we exercise, all those things. That's 50%. About 25% are your genetics. You know, what you're born with, you're gonna, and then about 15% is the environment, the air we breathe, and then about 10% is the healthcare. And so if we only focus on that 10%, we've lost. We are completely behind in the game. So we are really working pretty hard to focus on that 50% that's individual choices as well as the environment out there. So we have just this huge food component right now. So on the new Eskenazi Health campus, by the way, you will not find a deep fryer. They don't exist. You will not find a single sugary drink. You know, you won't find Cokes and Pepsis and Mountain Dews. They don't exist down there. We're not telling you can't drink them, but we're not going to sell them to you at our place. You know, you're going to have to bring them on campus. And we want to make sure that there are. So we subsidize the salad bar. So we allow people. The salad bar costs by the container, not by weight. And we encourage you to build ornate structures to get as much salad as you can get in there. Because our view is if you are eating massive amounts of, and we control what's on the salad bar, right? We're going to be comfortable that anything we put on that salad bar is something that we're happy to have you eat. So it's not filled with tons of croutons and but nothing wrong with croutons. But, when a person so we say. So we've actually had contests to see who can build the tallest salad the biggest salad with the, and it's, you know, it's $3 for a salad. So we're going to, you know, because we, so those were ideas that came from the our, you know, previously homeless cooks. And we had, in fact, we had this. So here's a great, I mean, nursing does all kinds of things, but here's just a very simple example of something nurses. So it turns out that we used to have in our old hospital tons of different cups, right? So you had styrofoam cups, you had cups that were sort of clear plastic, you had cups with little lines, and you had all these cups. And it turns out that those cups cost differently for each one. So the styrofoam cups are super cheap, they're less than a penny a piece. But the cups with the little lines on them that says, you know, with the little milliliters are actually pretty expensive. And the habit of the nurses, that's not a habit, so, you know, when someone needs a medication, you take the medication, you put it in a cup and you hand it to the patient. And they were putting it in these really expensive cups that were costing, and I say really expensive, they're probably 5 cents instead of the 1 cent. And we had a nurse figure out that, and look at the number of those cups that were those expensive 5-cent cups that we were using, that if every nurse for every script just used the styrofoam cup instead of those fancy cups, we would save $2 million a year. No, I'm lying about that. I'm lying. No. Okay. No, it was $80,000 a year. But still, $80,000 a year for cups. 80,000, because an 80,000, that's a new nurse. So you say, would we rather have another nurse, or would we rather use these little cups? And the answer was, of course, we'd like to have another nurse. But the way a nurse just went and figured that, and looked around and said, we've got all these different cups. I wonder what the different cost is. And then went to our finance team and asked them, looked at the quantities and figured that out. So I don't know if I answered your question or not, but yeah, but don't use those lined cups. That's the moral of the story. Yes, sir.
What's the role of fundraising and use of volunteers like in your operation?
Yeah. Let me address the latter and then I'll address the former. We love our volunteers. We have, I should have the number on the top of my head, but it's into the many hundreds of hours of volunteers. And those volunteers take many shapes and forms. So for example, one of our favorite volunteer programs is a pet therapy program. So we have people that come in with their certified pet therapy dogs whose sole job it is to bring their dog in and go around from patient room to patient room and have people pet their dog. And I'm telling you, our patients love just having a Cavalier King Spaniel running around their hospital, you know, on their bed, you know, licking their face. And we have everything from little toy dogs to Newfoundlands roaming through our halls. And patients are just ignited by that. To people who come in and just do nothing but read to our patients, right? And so we literally have hundreds and hundreds of volunteers, and it's incredibly important to us. We couldn't do without it. On the philanthropy side, for most of our history, we were a government hospital. For whatever reason, we never sought philanthropy. It was just not part of what we did. And when we made the decision that we had to build a new hospital, again, we didn't have a lot of money, so we were trying to cobble together any possible source. And so we made the commitment that we would go out and seek philanthropy as part of that effort, so that way we could actually have the funds to do it. And we'd never raised any money before. And so we said the first thing we'll do is ask our own staff to give. So we did a survey, and we found that the largest amount of money that a public hospital had ever raised from its own staff, and this, I'm not talking about the doctors. The doctors are in a different category. It's the ordinary, you know, the nurses, the therapists, the janitors, the cafeteria workers, the administrators. The largest amount that anybody had ever raised was Parkland Hospital in Dallas, and they had raised $80,000. That's a lot of money, $80,000. And so we said, you know, if we can raise $250,000. That'll be send a strong message to the outside community that we believe in this and they should give too. But we actually thought, I bet we can do even a little bit. So we thought we could even do better than $80,000. So we sort of internally, we didn't announce this, but internally we set a goal for ourselves, for our own staff, of $250,000, so 3 times the highest amount. So, so money is still coming in, but as of today, from just our own internal staff, they have given $2.4 million. And the doctors on top of that have given another $2.3 million. So we're at over $5 million just from our own staff. Now we set a goal of $50 million for the project. And sitting here today, we have been incredibly fortunate that our community has contributed $81 million for the new facility. And it's been overwhelming. That's something that, and people are still giving gifts. So it's enabled us to do things that we otherwise could never do. And let me give you some examples of that. By the way, you can cut me off anytime because I will go on forever. But we're doing some things that we're very excited about in the new facility. So, for example, we have a very robust public art program in the new facility. We have some fantastic art, and there is lots of medical evidence that shows that when patients and family members are exposed to art, exposed to natural light, and exposed to nature, that they heal better, that their length of stay decreases, their mood increases, their blood pressure goes down, their compliance goes up, all the things. People are just happier and therefore are healthier when they're exposed to all this. So we have this fantastic public art program. So when you walk into our new facility, I don't know if anybody has been over there. I invite you all to come over and see it. But you're going to see, particularly in the public areas, you're going to see lots of art. And all of that art was funded philanthropically. And that was, I'd be happy to defend us spending public money on art, but luckily I don't have to defend it because it's all been funded philanthropically. So we're very excited about the art, and it was able to happen because of philanthropy. We've got a very robust now music program, a particular philanthropist who I know is also someone who's given generously to Marion too, because I've seen her name, wanted to buy us a piano. And so she bought us this gorgeous piano, beautiful grand piano. And now, so it's played. We've got a formal program where we've got classical musicians who come and play it. But what's awesome is that we just put it out there, and we don't have a sign that says don't touch, we don't lock it, it's right there. And patients will come in, and people are very respectful. And so this happened the very first week we opened. This gentleman came in, and he's kind of coming for an appointment, and he sees this piano there. He doesn't even, he's a great big guy. He could look like he could be an offensive lineman for the Colts. He's got a big, it's cold out, he's got a big winter coat, he's got these hats with the flaps, and he just sees this piano. And he sits down, and he starts playing beautifully. He's playing gorgeous, just gorgeous blues on this piano. And then all these other patients that are running through, they just stop. And then they gather around the piano. Our staff starts coming out and listening. And he sat there and he played for 2 hours. He actually missed his appointment. We rescheduled, we got him in. But he played, and it was transformative for our other patients, as well as for him, to have this music all the way up and down the main concourse. But that was a gift, and so we're excited about both the formal and informal aspects of that program. So we're going to have concerts out in our lawn throughout the summer, and concerts throughout a couple times a week that formal musicians come in. But we also like the organic part as well. So yeah, philanthropy is very powerful, as you know from being able to be part of this exciting school and all of your education and the work you're going to do in the community. Philanthropy has played a part of that as well.
Guys, let's thank Matt for spending the afternoon with us and talking to us. Hate to cut the conversation off there, but let's give him a round of applause.